very honored to introduce our two presenters today. Our first presenter is going to be Mr. Terry Scoggin from the Texas Organization of Rural and Community Hospitals, and our second presenter will be Mr. Ryan Kelly, the Executive Director of the Mississippi, Alabama, and Arkansas Rural Health Associations, amongst many other things, but I'm going to let each of them introduce themselves briefly. So, Mr. Scoggin.
Good morning, it's Terry. There's no Mr. in this one, so let me share my screen real quick. Good to see you, Kevin. Well, good morning. My name is Terry Scoggin, and as Kevin said, that I was the interim CEO of Torch over the last few months, but I am a rural Texas boy. And I unfortunately look like East Texas, so a lot of the problems that go on in East Texas, I'm a shining example of hypertension and overweight and all those different things that go along. But grew up in Palestine, Texas. I'm a graduate of Texas A&M. And I've living a great life of football right now. But I've had the opportunity. I'm a CPA by background, so I love data and I love numbers. Worked in the Austin and high tech industry, but in 2004, it kind of changed my life. My boys were 8, 6, and 4, and I want them to grow up the way I grew up. So we moved to Mount Pleasant, Texas. I've been here 21 years. And they're now 29, 27, 25. And me and Tracy will have them our first Thanksgiving. We'll have as the adults and spouses this weekend. So we're excited. But they got the opportunity to grow up in East Texas like I did. And I love and have a passion for East Texas. Got into healthcare in 2012 when I left the local bank and became the CFO of Titus Regional. And I was originally the CEO of Titus Regional. And I was there for till earlier this year. And I just love it. I love rural healthcare. I have a passion for Texas rural healthcare. I love the ability that you have in rural to make a difference. And I hope you can see over the next 10 and 15 minutes, many of you that are on listening to this today, it's personal. And the difference in rural communities and urban communities is, we eat, sleep, and drink this. If you don't turn it off, if you're in healthcare in a rural community, you go to Walmart, you go to church, you go to the sporting events with your friends, and during COVID, you watched your friends die. And I think that's what makes this so personal. But to give you a little understanding about Texas, if you're not familiar with Texas, make sure you get my screen. Texas is big. And there's a lot that's going on in Texas, but you have 254 counties in Texas. 201 are rural counties, almost 80%. Texas is always going to do things a little differently. So HHSC defines a rural county as 68,750 or less. And we have 201 of those. 139 rural counties have hospitals. So there's 30% of our counties in Texas that don't have rural hospitals. So that's a crazy thing to look at. Texas is like the rest of the nation. We're older, a lot of Medicare, Medicaid. Texas is a non-Medicaid expansion state. I love this graph, and I just love I love data. And I'll try and not get too geeky today, but little map of Texas, you can see the lighter is the less populated counties, and most of those are rural. Of our rural counties, that we have 156 rural hospitals in Texas. PPS are 61, critical access are 91, and we have 4 rural hospitals. And I've already seen Justa in the comments. She's on here. She's CEO of one of our REHs here in Texas. We have 4 REHs. We had 5. Our range closed down. They're in the process of probably opening back up. So 4 REHs, a lot of critical access, 98-ish independent hospitals in Texas. So about 63% of those 156 are independents. And Titus was the last independent in Northeast Texas. So I had just the wonderful opportunity to work for them. Then worked for Hunt Regional for the last few months, still in Northeast Texas, their CFO. And then John called me in September and asked me he was going to need to take a leave of absence to work on the OB3 application for Texas. And I jumped at the opportunity to become the interim for Torch for 60 days. And it was my dream job. And I've had the opportunity for the last 60 days to travel Texas to see how the sausage is made, get a little feel for Ryan's background and as he deals with all the states that he deals with, just to see how many great things are going on in rural. So there are challenges in rural. I'm going to talk about them, but I want to not get too deep in them. I'm a big health equity. I'm a graduate of A&M, like I said, but I went to Texas a few years ago for the Master's in Healthcare Transformation. Health equity is important to me. I'm a big believer in social determinants of health, or here in Texas, non-medical drivers of health. Texas has to be special. And but I had the opportunity at Texas to really get into different causes of what's going on in the rural communities and equity. And so I love data. And I really believe in that power of data. Here's a slide that just really tells you, we all on this phone call today, if you're living in a rural community, you're making a decision to live a shorter life. And, that Texas rural benchmark there is the counties in Texas that have 68,750. I love breaking it out by the rural, by Texas, and then the US, but you can see that you have a little shorter life. And I love showing this slide because this is my family. I'm in Titus County. My son is in Williamson, which is Round Rock. My other son is in Pflugerville, which is Travis County. And my youngest, my baby, is in Dallas. In that, so you can tell my boys will live longer than me because I choose to live in a rural community, and that's important. So one of the things that my passion is to try and minimize that, and try and how can we improve life expectancy. I tell people all the time, once you see this, you can't unsee it. I did the same thing for Titus County. This is our town of Titus, our county, and our town of Mount Pleasant. We average a 77.4, which is a normal average for life expectancy for a rural. But what's really interesting is if you live by the country club, you live north of the town, you're living to 78. If you live in the south part of the city, you're living to 69. There's only 4 miles difference down 271 from the country club to right by our chicken processing plant. But you can see the things when you start looking at your own community. And I'll encourage you to focus on that as we are leaders in rural healthcare that are on this call today. Understand your community and really get into the data. You can see Texas, coronary heart disease in Texas, 146 per 100,000 for deaths compared to the US and Texas, and way above the target from that. Same thing with stroke, 63.2 versus 100,000, way above. Infant mortality, and this one is close to my heart, especially in East Texas. You can just see, Texas and the United States have made improvements in infant mortality, but rural has not. So that's one of the concerns and the things that when I focus on change. We talk about challenges, you're all comfortable, you all know about the closures. 195. One's opened back up in the last few weeks because this was 196. But you can really see in the South, and especially in the areas that Ryan's going to talk about and that I live in, you can see those closures. This is what Texas has looked like, 25 closures since 2005. Good news is it's slowed down a little bit the last few years, but as many of you know, we're on the verge of so many things. And in 2014, there were 5. I actually lived within 35 miles of 4 of those. And I was in Franklin County on December 31st, 2014, when Mount Vernon lost their hospital, and it was devastating. We were taking over the EMS, so it's close to my heart that I don't want a community to ever go through that and to see it. And, Kevin said everything's good with the federal government opening, but, these are the challenges that we're all dealing with. Even with the opening coming up, you still have possible Medicare sequestration. You've got the rule adjustments that got extended, but, these are the challenges. But what I want to focus on today is you hear about all those negatives. What I want to focus on for 10 more minutes is just the positives. There's so many positives going on, especially in Texas right now. Our last legislative session, Texas passed HB 18. Dr. Villigran talked a few minutes ago about part of that. There's hundreds of $1 million that's going to be that Texas is dedicated for those 156 rural hospitals, for stabilization, for infrastructure. One of them is for a financial leadership program she talked about. There's going to be 4 universities in Texas that are going to be focusing on that as part of this bill. But, we also got our Medicaid cost up in this, protecting our OBGYN, our labor and delivery cost. Texas and Medicaid is supposed to pay cost. HB 18 was a huge impact, and the governor came to the Torch Conference in September. We had the privilege of being on stage when he signed that bill. But there's going to be a lot. HHSC is doing a lot of positives over the last 4 to 5 years for rural communities in Texas. And this latest one is going to do some great things, focusing on data, focusing on vulnerability. There's a lot of things that are going to come out of this. So we're excited at what Texas is doing and really pushing these rural communities where so many of our hospitals are on the verge of closures. They're doing some great things with HB 18. that's excited about that. And I've had the opportunity filling in for John to meet with HHSC and go behind the scenes and see some of the things. And I'm going to tell you, there's some really good people who care about rural communities at the state level. So a lot of people, get down on the governor's office and the state offices and some of these legislative stuff. There's a lot of people doing some great things and they're passionate about it. So I'm excited. That same day, we also signed HB 3000, which is going to put new ambulances in many of the rural counties across Texas. So this one was focused on EMS and that. But if you live in a rural community, if you've driven the Panhandle, you've seen why you need some new ambulances in those areas. So two good things that are positive on that one. And the last one's OB3, or rural health transformation. There's some negatives about it, and it's going to hit some states hard. But from a Texas perspective, John and Tori at HHSC and April, the team over there, they did a phenomenal job. And I think they've put a great application. I've read it several times. And but there's some great things that are going in that application. Most of it's half of it is going to go to all states split equally, which hurts Texas. But the other half is going to be a competitive grant. And I hate those words, competitive grant, in a rural community. But I think Texas did a great job. They invited John to represent rural Texas and participate in it. We believe that Texas is going to get one of the larger shares of that second half. Would be disappointed if we don't, given so much of the good things going on at the state level, the collaboration across the state. But you can see some of the things Texas is going to focus on, making rural Texas healthy again, chronic disease, that portal, trying to increase our AI, trying to increase our EMR access and all those things. We want to use this opportunity of how do you expand and innovate. And we talked about it before everybody got on, is this is our opportunity with the rural health transformation over the next 2 or 3 years. We've got to get infrastructure. I've seen too many communities hurting right now, but we've got to improve our infrastructure so we can innovate. So we believe Texas has the right amount of infrastructure and capital equipment to start. I was blown away over the last few months as I've traveled around, seeing how many, just not hospitals. That's a mistake I've made saying rural hospitals. It's rural communities. They're having water issues and other issues and infrastructure issues in the town, which hurt the hospital. But I'm excited that there is money for capital infrastructure as we fix some of our holes in Texas between RHTP and HB 18 from the state. I believe Texas will have a nice infrastructure packages. Then we can start focusing on innovation and getting into it. And I'm in the process of leaving Torch. I'm wrapping up this week, but I've had the opportunity that John came back last week, so we're excited about giving him the baton back. But Torch has been a great institution for Texas, really focusing on how to help the rural hospitals. John was the CEO of Childress, so he understands, what the rural hospitals are growing. But several things, we talked about those rural wins and some things that Texas is doing that I think are positive. Is Texas has started a clinical integrated network. I'm a big believer in this. We currently have 42 hospitals and a lot of their clinics that are part of this. It's in the beginning stages, but Texas has a legal entity that really can, the rural and independents working together can I don't want to say battle, but work with or collaborate with the payers and the urban hospitals to benefit the Texas communities. We also had something that was passed to 2 legislatures ago, Texas Tech. I've seen some of their team on this call today. We've got a rural emergency department telepsych pilot program. We just got it reinstalled this next legislative for 2 more years, but we're pushing 23 hospitals in Texas and the opportunity for 15 more. But this provides from 7 to 7 every day behavioral health for our emergency departments in Texas. Titus, where I was at, averaged a census of 4 to 5 behavioral health patients a day in the ED. Average length of stay was 3 to 5 days. The longest when I was there was a gentleman who was there 6 weeks. So really, this program over the last 3 years had a huge impact on behavioral health. And I see what it's doing. One of the things is, I think Titus was 98% hospitalization on behavioral health patients before this. And now after this program from Texas Tech and Torch, 35 to 40% hospitalization. So 2/3 of the hospitalized behavioral health patients could go home by putting this program. So another great thing that's happening in Texas. But There's a lot of negatives, and there's a lot of hospitals over the last few weeks that I've seen, last few months, I'm sorry. I was surprised about the number of hospitals that called each week struggling to make payroll. Those are the things we want to focus on to help those hospitals. But at the same time, there's a ton of great things going in rural communities. And I think the rural health transformation is one of those, is a great opportunity for us. I really hope and going to work hard to make sure that we take advantage of it. Because I do think we have to innovate we have to fix infrastructure over the next 2 to 3 years so we can use years 3, 4, and 5 to innovate and really change how we do healthcare in rural communities. And Doc, I'll pass the baton to you and Ryan, but I'm trying to stay positive because I think there's a lot of great things going on in rural communities, and I love living in rural. So.
Thank you so much, Terry. I really appreciate that. I will now turn it over to Mr. Ryan Kelly, and he's going to tell us a little bit about some of the initiatives going on in Mississippi in particular, but also I think talk to us a little bit about just some of the broader strategies for advocacy and kind of ways that we can engage and, ways that people in community organizations or in a variety of positions, I think can kind of just be present kind of in this policy development space. So, Ryan, I will turn it over to you for a brief introduction and for sharing your experiences.
Absolutely. Thank you, Elizabeth. And it's really a pleasure to be on here. Terry, thank you for all of your great comments there from the first presentation. I actually adapted my presentation as you went on because I realized there's a few things I probably don't need to cover and a few things I might need to add. So I'll send this to you guys with Texas State after this for the sake of your files. But my name is Ryan Kelly. I serve as you mentioned earlier, the executive director of several rural health associations, in addition to executive director of many other healthcare associations in the country. Through my role in Horizon Professional Services, we just run a bunch of associations. That includes Mississippi, Alabama, where I serve as the executive director, and then the administrator over Arkansas and Arizona. So I actually added a few details of all 4 states, but I'll focus more of my attention on Mississippi today because it's the one that I've been with the longest and the one we do the most legislative outreach to currently. But just know that my comments do reflect most of the policy positions and issues of all 4 states, and really most likely every state from everyone who's on this call right now. You are all going to, as when Terry was going through some details about Texas, you're going to be nodding your head because they're the same things we all face. And so I'm going to go specific to unspecific in this presentation. And I kind of like that format because we dive into the problem. It's almost like the reverse iceberg. You dive into the problem and then you go back to the solution afterwards. So why rural health matters, this is the slide I'm not going to really focus on because Terry did a fantastic job at saying why it matters to us. If you live or work in a rural area, you know the challenges that are faced with all things in rural, whether it's education or workforce or healthcare. And all 3 of those really form as a 3-legged stool to help a community survive. If you don't have good education, you're not going to drive in citizens. If you don't have citizens, you're not going to have a good workforce. And if you don't have both education and a workforce, you're not going to have healthcare. And so we need all 3 to do well in areas. And this is a real challenge for communities that are dying or have shrunk over the years. And so this is one of the greatest challenges I know many of us have is how do you take a community that used to thrive and is now not thriving, but still give them the quality of care that they need? And so that's what a good bit of the work that we do in addition to helping our organizations not just survive, but also thrive. I'll put in a few maps here of Mississippi, Alabama, Arkansas, and Arizona, just so you can kind of visualize where the healthcare access points are and where they are not. On all 4 of these maps, the slight beige colors here, so you can see the Jackson metro area, what we call South Memphis, which is the South Haven Olive Branch area, Hattiesburg, which is kind of clustered here, and then the Mississippi Gulf Coast. These are our urbanized areas in Mississippi. Everything else in white is rural, which you can see is more than the vast majority of the state. Mississippi is one of the states where more than half of the population are in a rural area. And so you can see on this map here, we have 29 critical access hospitals, 6 REHs, almost a quarter century of rural health clinics, 245, which is up a little bit from where we had been. 238 individual rural health federally qualified health center locations, and 40 PPS hospitals. And you can see them clustered on the map here. Most all of our urbanized areas and large clusters of rural areas have health access. But what does that health access look like? If you're a rural health clinic, you might be a trailer on the side of the road that's open one day a week, or you might be a fully functional multi-specialty clinic with after-hours care. It really dramatically changes depending on where the population is and what the area is. Going on to Alabama, you see very similar. You have more clustered areas of population, so Alabama is slightly more urban than rural, but not by much. 8 critical access hospitals, 3 rural emergency hospitals. There's actually a legislative reason why Alabama has so fewer hospitals. It deals with a minimum bed size requirement in the state, which I see as a major issue. It's actually where I slightly differ from the Hospital Association in the state. I think we need far more critical access and rural emergency hospitals, but we do have some. 163 rural health clinics. Part of this is because we have fewer critical access hospitals, and rural health clinics are a major driver behind the rural hospitals. So that's why there's fewer clinics in Alabama than Mississippi, but there's still a good many. 126 federally qualified health centers and 42 short-term PPS hospitals. Moving on to Arkansas, you can see a little bit more of a distribution here, clustered urban areas here in central and northwestern Arkansas. 28 critical access hospitals, 149 rural health clinics, 20 short-term PPS hospitals, 5 rural emergency hospitals. This number will go up soon, and 163 federally qualified health centers. All of these numbers will increase soon, particularly the rural emergency, and I would see the rural health clinic and federally qualified health centers increasing as well. Then Arizona, obviously much more of a frontier state, as we see out west, which is very different than rural because it's like rural on steroids. You might go, instead of going 20 miles before you see anyone, you might go 200. And so that makes our western states far different. And if you're in any of our western states, you're very familiar with the frontier aspect of rural healthcare. It's very different. In Arizona, obviously, you can see your clustered urban sites here around Phoenix and down south. 17 critical access hospitals. There are no REHs yet, but there will be soon. 52 rural health clinics, 75 QHCs, and 12 short-term PPS hospitals. That gives you a little bit of a visual anyway for those 4 states. Coming back more central to Mississippi, and that's where I'll kind of land on the rest of this presentation, because every state is going to be a little bit different with the Rural Health Transformation Fund. And again, Terry talked a little bit about that for the state of Texas. Very excited to see what Texas does. I really liked their proposal and what that plan is going to look like. Every state will look a little different on what they decided to do. If you're not familiar, the Big Beautiful Bill provided this $50 billion for a rural health transformation plan through this Rural Health Transformation Fund. This money, about $25 billion, is equally divided among the states, and the other $25 billion is in a second wave where that will be determined on the rurality of the state and then also the success of phase 1. And that's where every state is going to look a little different in these 10 buckets of options that they gave through the bill, where you can select several of those options through this open process of gathering information from the states. I was quite busy a couple months ago, as I know several of you were, in submitting information to the governor's offices and working with the various governors on those plans for the submission to CMS. And of course, at the end of this year is where we will hear back from CMS on the approval of those plans and then the money being distributed to the states shortly thereafter. So in Mississippi, the Rural Transformation Fund, the goal in this state, and really the goal for most, is to transform service delivery models. One thing that I keep hearing is a false phrase, if you will, is that this is supposed to plug holes that from cuts to CMS through the one big beautiful bill. That's actually not at all true. This is not designed to plug holes. If you did, simple math would tell you this is not going to work. The hole is way bigger than the plug. This is designed to transform healthcare in rural areas and providing a good bit of money to be able to do that. So we're hoping to be more efficient, more effective in delivering healthcare in rural areas. And there's a whole bunch of things we can do to do that. And this money would be driven towards those models. So transforming healthcare service delivery, expanding rural health access. The use of technology is really big in the Rural Transformation Fund. Dr. Oz and RFK Jr. really like the use of technology through innovation. And so that's a linchpin in most of these proposals that have been submitted. And I'll go into some detail on that in a moment. And then sustaining local essential services. And that might be EMS, definitely includes providers and other similar services. And I would say hospital and clinic sustainability is a huge part of that as well. Each of these will be administered through the various governor's offices in each state, coordinated with the various partners that have been involved. And then the strategy for this one, of course, came from the governor's office in Mississippi and part of the governor's rural health plan. So in Mississippi, I actually helped to lead a group of individuals for our previous governor to establish a rural health plan in the state that is still actually the plan. The new fund here will actually update that plan and create a new one for us because that was a pre-COVID plan, and we are still limping along, and we've accomplished many of the things from the plan, but it was about a 25-step plan because there is no silver bullet to establish a sustainable and growing rural healthcare system. There's a bunch of things that have to be done. So we did many of the things, some of the low-hanging fruit, some of the challenging things. This next plan will evolve from our original plan and act as our plan moving forward for the state. In Mississippi, at least, there's 6 core initiatives for the Rural Health Transformation Fund for the state. Statewide rural health assessment, which I kind of mentioned. Part of that will go into this, a plan. Coordinated regional integrated systems. This is something we've talked about for a long time. And I would say many of us have talked about this, where every hospital doesn't need to do everything for everyone. Instead, we need to be more efficient and effective with how we do things. So you might have a cluster of hospitals. One might be your birthing center. One might do cardiology. Maybe one does oncology. One does neuropathy. That way, you don't have to have one provider for every one of those services in every facility, just draining your depth of skill-based providers. If you want to give a football analogy, it's like a team that has the depth of the University of Alabama versus a team that has the depth of, I probably not better use an analogy of a weaker team here, but one that has a couple of skill-based players and they are only on the field a couple of times in the game. You can pick which one you want to put in that one. University of Texas, Texas A&M. Let's give some powerhouses in there. LSU, Ole Miss now for our SEC people. Teams with depth. That's what we want. And so we want to do that through these regional integrated systems. Part of that gets into the workforce expansion initiative as well, although that really is going to focus, in my belief, on the entry-level providers, EMTs, paramedics, RNs, LPNs. The things that we are the weakest on in the state currently are the things that we need to focus on the most. And there's others as well, radiology technicians and the like. We know nurses, we know physicians. They're always a challenge. But right now we have empty bed space, as many of you do, because we don't have enough nurses to take care of the patients that would be in those beds. So now there's empty wings of hospitals where we have patients for them and we have the equipment, we have the space, we don't have the staff. And so that's going to be a huge aspect for it. Health technology and advancement and modernization. I kind of covered some of that. A lot of that bleeds into number 5, which is telehealth adoption and provider support. Mississippi has been one of the leaders in telehealth since 2013. We like to keep that banner pretty high. And so we've adopted telehealth really well as a state. Certainly hurt us when the CR didn't pass, as it did everyone. And the telehealth rules for RHCs, FQHCs, hospital at home models, and the like went away there for about a month and a half. Fortunately, that is back. We hope that gets permanently adopted, but we hope that there wasn't too much damage during the process of that fading away there for a bit. Telehealth is huge. We think that's one of the greatest access points we could have. It is not the end-all be-all for all things, but it is. If there's a silver bullet, it's the closest thing that we've got to one. But again, it will not fix all of our issues. It's just going to help in some pretty key ways. And then number 6, and possibly as important as anything, is the building rural infrastructure growth and efficiency. We've got to support our facilities. Many of our hospitals are still old Hill-Burton hospitals that were built back in the 60s and the 50s, and you can tell when you look at it. As much as you try to put lipstick on the pig, that hospital needs some work and possibly needs to be completely rebuilt. We can't do all that with this money, but there are some strategic things we can do. We use some of the ARPA funds during COVID to do that, and we can use some of this money now to do that as well. So I'm going to kind of transition now to the lobbying and advocacy role. What do we do? How do we do this? And again, some of you are seasoned professionals. This is going to be simple for you, and others, you have no idea what lobbying and advocacy looks like, and that's really the goal for you in this. From a practical standpoint, we do legislative tracking. We do issue briefs to our members. Our board is kind of centrally focused on this in addition to our legislative committee, but then we send it out through our weekly newsletter for all of our members to see. We build coalitions that usually works through our legislative committee. And that's basically anyone who wants to be a part of it. Hospitals and clinics are huge, various different agencies in the state, and some of our faculty and even students will get involved in that from time to time. And then we'll do some public awareness and positive story campaigns depending on what the issue is and what we need to do, particularly if there's something we need to activate our members to go and call their state legislator or their federal legislator and encourage votes, then we'll go and push those as well. And then the biggest thing for this, if I could just say one thing, be a trusted partner for your different organizations and your legislators. Be the go-to organization. And I will tell you, a lot of times that means you don't need to dive into the controversial things unless you absolutely have to. You need to be a partner with them to where you can be a sounding board, you can be a trusted advisor, and they know they can come to you and get facts, not spin, but facts. Now, if we lean on facts, it's going to tell the story itself. We don't have to spin it. And that's one thing I really wish we could get back to as a nation, is going to fact-based legislation rather than just what someone thinks because they woke up on one side of the bed. So being a trusted partner with the governor's offices, with the Department of Health, state legislators, and others, we get calls from them frequently asking, what is our thoughts on this? They'll send us, our legislative aides up in D.C. will send us legislation. Hey, Ryan, what do you think about this? Is this going to be helpful for us? And then we'll say yes or no, and then we'll give some comments either way. Usually I like to let them make that decision, but we'll kind of lead them in the right way based on what we think and to get some data either way. And that way they know we're not just blowing smoke. We're a trusted advisor. Rural health legislative highlights, and some of these are federal, some of them were state, but telehealth flexibility extensions, that one just passed, thank goodness. Hope that continues through January and then on. Maternal and behavioral health integration programs. Maternal health is just pivotal to us right now. As Terry mentioned earlier, we've got to do so much in this area. And that's a deep dive that I'm not going to jump into now because we'd be here all day, but it's critical. And for those of us that are fathers or mothers, you know how important it is for us to have quality maternal health, both before birth and postpartum. Workforce recruitment and retention, rural loan forgiveness. That's a really good one. It's not the perfect solution, but it's a good solution. And it's one that's a fairly easy one to jump off into from the beginning. Critical access hospital stabilization grants. It's not fixing everything, but it is helping. And then broadband expansion and digital infrastructure. Mississippi has done phenomenal on the broadband expansion, which I'm very excited about, because if telehealth only works if you have the broadband to be able to keep up with it. And then this gets into education and everything else as well. My wife is a teacher, so she can very much appreciate the high-speed internet that they have at their rural school. Advocacy versus lobbying. So again, this is elementary for some, but for others, you've heard these two terms. You don't know the difference between them. Advocacy is the one that we're all safe to play in, depending on your tax status and what you do. Literally everyone on this call can advocate for something. That means you're not asking a legislator to vote for bill numbers, 1, 2, 3, but you are advocating a policy position based on what your organization does. That goes for our universities. That goes for every institution in here, every hospital, clinic, whoever you are. You can advocate, and you can legally advocate. And there's really nothing they can do or would want to do to stop you from advocating. Your tax status does not prevent you from doing that. So that's this education. This is, like National Rural Health Day, advertising that. Even doing media outreach and talking to the press, although there's maybe some policies internally about doing that and who would do that. But these are things you can all do. You are all individuals. You have a voice. You can do advocacy. That just means you don't get to tell legislators you want them to vote for a certain bill. That becomes lobbying. So there is IRS requirements on lobbying. 501c3s can lobby, but you have to be very careful. It has to be a very small portion of your income and your time. The IRS is very unspecific on what that means. So my interpretation is 25%. Some are more liberal, some are more conservative on that. 25% of your money and your time is where I think you're in the safe zone. I've heard upwards of 50%, and I think you're probably okay there. Certainly wouldn't go above that. That's where you're going to be in the danger zone. I've heard as low as 10% is wherever you feel most comfortable. Again, the IRS does not necessarily give the most specific guidelines on what they mean by a substantial amount of your time and money. So it's kind of up to interpretation on that. 501c6s, on the other hand, are very safe to do it. They're kind of built for the trade associations to be able to go and to lobby. The difference is 501c3s are tax deductible donations. C6s are not, and that's why C3s are not supposed to be able to lobby, because you shouldn't be able to get a tax deduction and lobby for that organization or that issue. And so, of course, examples of lobbying, you're going to Capitol Hill, you're meeting with legislators, you're asking them to vote for this legislation, you're donating money to legislators for their campaigns. This is lobbying. And again, lobbying is fine. You can do lobbying, but you have to be in the right tax status. You have to make sure this is approved through your organization. Like, again, state-based organizations. Elizabeth, y'all probably can't lobby through Texas State, would be my guess, unless you have an assigned lobbyist, and then their salary is probably coming from an indirect fund rather than state funds. So you have to be very careful about that if you're a state organization or if you have a 501c3 or similar tax status. And I'll entertain questions at the end about that. Lobbying with purpose. Don't just go up there and talk. So many people I go and I'll bring to Capitol Hill or I'll bring to the state, and they'll go for an hour and a half and just machine gun talk on things. You've got to go for a purpose. And I would say no more than 5 things that you're going to talk about, because otherwise they're going to go cross-eyed and they're not going to listen to anything that you're saying. So try to focus your intention of when you're talking to a legislator or a staff member about an issue. Come in with a packet, because they're going to want to look at it later. So come in with something that's going to have a good shelf life. I usually like to do a 3-ring binder or something with a coil foil packet because it's got a good shelf life versus something stapled that they're just going to throw away most likely. So something that's going to stick around and may have last is going to be helpful to them. Talk to the aides and the legislative assistants. They are great, and they are largely what drive legislation. So the legislators are great. They're always fun. They're good for photo ops. But for the most part, and this isn't all true, but for the most part on the national front, you're better off talking to their staff, because they're the ones that are going to be getting legislation in front of those legislators. On the state side, most don't have staff. Some do if they're a committee chair, but most don't. And so talking to the legislators directly is the way to go there. And again, be that trusted partner with them. If there are committee hearings, those are great ones to be a part of, because you can join a number of other people in advocating for certain positions. Helping to draft legislation, normally, and sometimes outside organizations will draft legislation, but often the legislators themselves are drafting it, but you can help them along. And again, using AI right now, probably a decent way to help draft legislation, because it can search up previous legislation, it can get into the right language depending on the state, and it helps to give those legislators a head start if there's something you can go ahead and jump into. So I definitely recommend using some artificial intelligence to be able to get you going on this, because it's hard to start from scratch. And I've had to do that, as many of us have. Starting from scratch on legislation is challenging. And then, of course, coordinating joint advocacy is always helpful on really hot button topics. So if you're a Medicaid expansion effort, getting multiple organizations together is always a good idea versus trying to do it solo. It adds power to your voice, and it certainly numbers will speak. Strategies for effective policy engagement. A lot of this is what I've already said. Relationships, storytelling, building collaborations, and then follow through. When you go and talk to a legislator, follow up with them. Thank you for visiting with me, Senator Blackwell, or thank you for Liz for discussing this legislation with me. Here's a digital copy of the packet I left with you. If you have any questions, please let me know. Something simple. Keep the relationship going. Keep the conversation going. A lot of things are out of sight, out of mind. If you don't focus on it, if you let it pass by, then they may forget about it as well. That's a brief overview. I'm happy to dive in deeper, and I know Terry has been doing this for a long time as well, both in the state and the national front. So this is went specific to high level on the lobbying side, but this is something we're all passionate about, and we are very happy to be here to talk to you about it.